venue. So we're looking into that, working on that, but we'll do an in-person CE on July 29th. Like always for these webinars, we will send out the CE verification, recording of the webinar, and the handouts, as well as a survey. So Dr. Lukin was kind enough to send some handouts. I'll send those out either tomorrow or Friday, but you'll get those. You can do Q&A. You can ask some questions during the presentation via chat. I'll try to catch them, or Dr. Lukin might catch them and she can answer them on the spot. Otherwise, we'll do, if we have some time at the end, we'll do a Q&A, little Q&A session. And lastly, please mute your mics and turn off your videos to reduce any distraction during the webinar. You can, if you want to turn on to ask a question, I'm sure that's fine. And lastly, I'd like to introduce Dr. Lukin. So Dr. Laura Lukin has been practicing general dentistry since 2006. During that time, she's developed a passion in airway development and maintenance. She's the founder of the Houston Airway Study Club, which now consists of over 100 healthcare professionals in different realms of the healthcare world. She is also a member of the International Affiliation of Tongue-Tie Professionals, American Academy of Physiological Medicine and Dentistry, Academy of Laser Dentistry, American Academy of Sleep Medicine, International Association of Orofacial Myology, Spear Education Faculty Club, Academy of General Dentistry, Texas Dental Association, and ADA. So without further ado, Dr. Lukin. Dr. Lukin's there, right?
I'm sorry. I was trying to get.
There it is. I was like, I'm not gonna know how to give this presentation.
Hang on. I'm just gonna try to get back. It's not listening to me for some reason.
No worries.
There we go. Okay. Well, it'll let me go forward. It won't let me go back for some reason. There we go. There we go. Okay. All right. Okay. Well, I am Laura Lukin. I've been practicing general dentistry for 15 years in the Katy area. I'm also practicing in Sugar Land as well now, but in a limited capacity, more for airway patients and tethered oral tissue patients, which we'll kind of talk a little bit about that. A little bit about how kind of I ventured into this. I've been involved with Spear for Spear education for several years, and my husband and I have been going to Spear summits, which are for faculty club members. I was there a couple of years ago, and we hang on, my screen's not wanting to advance. There we go. We listened to this lecture by Jeff Rouse about airway prosthodontics, and it blew me away. It was crazy, all of the light bulbs that went on when he spoke about the relationship with dentistry and airway, and why it's so important for us in the dental field to be involved in this. So now that's, I guess, maybe a little bit of a disclosure. I'm a mentor for the Airway Pros course at Spear. I'm a KOL for a Solea CO2 laser from Convergent Dental. And that's about it. I guest lecture for the IAOM courses, an intro to orofacial myology certification. So that's about it. These are my favorite smiles. My husband, he's also a dentist in Sugar Land. He has a practice here with his dad, and they are partners. And so I come in there and I do a little bit of this stuff there. These are our three girls. I will go through a little photo album because they love that I share pictures of them. Real quick, we're a little beach bum family, and so these are this was a sunrise little surf session with my girls. This one is my oldest, and she did her first surf competition at it was in Galveston. Little waves, but cold. And videos aren't too loud right now. Later, I'm going to want the videos to be loud because I'm going to be showing some other videos. This lecture is full of videos, so I hope that they come through to your computers. And on a couple of them, I will ask that you put your volume up so that you can hear some of it. Anyway, my little girls, they're little, just like me. That was her competition. Those two girls right there were a couple of years older than her, and she's already a little tiny 10-year-old, but little people can do big things. So this is my middle one, Gabby, and she thinks she's a skateboarder. She's getting into skateboarding. So this is the one that, oops, I'm gonna have to go back here. This is the one she likes to show people. Oh gosh, sorry. It might not let me play both of them. The other one is the one of her wiping out. Anyway, okay, so getting into airway focused dentistry, this is kind of how I see it. If we're using a wave analogy, I think that traditional dentistry is changing dramatically. And it's not only because of technology, it's because of what we know now. It's what we're learning, and we're coming upon all these different connections that with the whole craniofacial complex and how it all interacts. So I think that traditional dentistry is out the door soon. And I think that we're all going to be more airway focused because we're going to be learning about these things. And once we learn, we can't unlearn it because it all makes so much sense. And it's just, you know, at least to me, it's very eye-opening. It kind of made everything to me in dentistry make sense. All these, you know, little problems that I'd come up against with patients with, you know, bite or, you know, gag reflexes or things like that. It just all comes together with airway. And it's a big umbrella. This is why I don't want to just speak to sleep apnea. I want to speak about all sleep disordered breathing because it's a huge spectrum. And we do, you know, we kind of miss the boat if we only focus on obstructive sleep apnea, which is the end of the spectrum. There's a whole, you know, continuum before that. So what I hope that we start focusing on is way over here so that we don't end up on this end over here. So that's my goal. In 2017, the ADA issued a policy statement. Dentists can and do play an essential role in the multidisciplinary care of patients with certain sleep-related breathing disorders and are well positioned to identify patients at greater risk of SRBD. In children, screening through history and clinical examination may identify signs and symptoms of deficient growth and development or other risk factors that may lead to airway issues. So, you know, when the ADA is saying this is something, we should pay attention and start making our, you know, our changes accordingly. And it doesn't have to be a full transition of how you do things. It's just incorporating a little bit of this into it because it all fits in well if you just kind of let it happen kind of organically. I hope that, you know, in some small way, each of you may take something back. Some of you are very knowledgeable in this subject, and some of you may not, you know, have heard much about it. But regardless, I hope that each of you will take something back with you and kind of let it grow. And, you know, hopefully, you know, my goal is, you know, I want to make an impact on what I'm doing. And it's dentistry can make a huge impact with these patients. We are the ones that see them more regularly. I don't know about you guys, but I don't go to my PCP every year. I'm very bad about getting my physicals and all of that. But even so, how often do they go and look in your mouth? I tell my patients the eyes are the window to your soul. I think the mouth is the window to your body. So we can learn so much. We know so much from just looking in the mouth. So hopefully we'll learn more about that. I'm sorry, my dog is scratching at the door. I'm just gonna open this. You all will constantly hear us scratching otherwise. I'm sorry. Okay, so I got so obsessed with this. And I also, I know, you know, there are a lot, y'all, as hygienists, you want the doctor's visits to be short and sweet and kind of to the point and all of that. And you're thinking to yourselves, oh gosh, they're going to start talking about something else and it's going to take longer. And I've got my next patient already in the waiting room, all of that. It did get lengthy in the beginning before I learned how to condense my spiels. I also, through urging of one of the hygienists that might be on here, I don't know, I built a website. Well, I didn't build it, but I put together a website with some information on it. It's nothing fantastic, but it is a kind of portal that I can direct patients to, or anybody to, professionals, that I have some extra information on there. Hopefully some things that tie things with airway and sleep apnea and dentistry all together. There are links to articles on there. There are links to lots of literature. So you can click on patient tab or professionals tab and go and find different articles linked to different things associated with airway, sleep apnea, and things like that. That's my handle on Instagram, which is mostly geared towards other professionals and kind of being on the same page and all of that. So, okay, so I guess going back to it, so why is sleep so important? So, you know, it used to be that, you know, the saying is, you know, I don't need to sleep, I'll sleep when I'm dead. Well, the fact is that you're going to be dead a whole lot sooner if you're not sleeping. If you want to kind of dive into that, this is a great book, Why We Sleep, by Matthew Walker. He also does a TED Talk, which is really interesting. So you could go check out a TED Talk by Matthew Walker and start with that, and that'll kind of give you a little glimpse if you haven't seen this. So, you know, sleep should be restorative. It's necessary for health. That's when we rest and repair our muscles. We organize our thoughts and our memories. Basically, our sleep is kind of like, it's like our therapist. So we need it just to function mentally and to be kind of to reduce depression, anxiety, things like that. And we'll kind of maybe dive a little bit into that a little bit. improper daytime and sleep breathing adversely affects all aspects of health, mood, energy, focus, and memory. So chronic inflammation is what you get from lack of sleep, lack of quality sleep. So there's quality and quantity. You can be asleep for 14 hours, but get poor quality sleep. So you're not necessarily meeting these goals. Sleep stages, they've kind of condensed them into 4 stages, and you have 3 non-REM stages and then REM sleep. Stage 1's kind of your transition, you're transitioning into sleep. Stage 2 would be your first stage of true sleep. And it says I have 10 to 25 minutes there because this is a cycle, right? You're gonna go through this cycle a few times each night. The goal is 4 to 5 times each night. So you kind of have to be sleeping for your 7 to 9 hours in order to reach those, that 4th cycle, 5th cycle, where your REM sleep starts extending a little bit. Your deep sleep, your stage 3 deep sleep is your restorative sleep. Really, that's your immunity. That's the important aspect of your stage 3 deep sleep. Your REM sleep, okay, that's where, they call it the dream sleep, although you can dream in other stages of sleep. But that's where you've got your the rapid eye movement. So there are 2 things that should be moving during REM sleep. That's your eyes can move and your diaphragm. Other than that, everything kind of relaxes, right? And that is when we start to hear, the snoring or the obstructions, or that's when the obstructions occur. You'll start to hear them in the deeper sleep, but that's when they occur. And then that's when you can not hear it, when it stops, because everything gets obstructed and there's no breathing taking place. So that's when your apneas will be diagnosed, or that's where you'll see that. Your REM sleep, important for your anxiety, depression, and pain management. So, if you have poor sleep, if you have poor sleep quality, or even transitionally, so if you have a week where you go with poor sleep, your pain threshold will decrease. So you will start to feel pain more and more easily in that case. But you think about that sleep deprivation over a long period of time and the effects that it has cumulatively. It's a big deal. So sleep-related breathing disorders, there are different acronyms. So that's SRBD, SBD, sleep breathing disorders, or sleep disordered breathing. They're all kind of synonymous. They're a spectrum of breathing anomalies. And then that includes kind of OSA and then upper airway resistance syndrome. I'm not sure if you all are familiar with that, but that's huge, huge, huge. So a big spectrum before the obstructive apnea. And then you have your insomnias, your hypersomnias, your narcolepsy, parasomnias, your sleepwalking, things like that. Okay, what does OSA look like? Let me see if I can play this video. So this is one of those that you'll want your volume up, and I'll try not to talk through it. And then you might want to drop your volume down so I'm not so loud. So obstructive sleep apnea can be characterized by pauses in breathing, gasping, or choking while sleeping. I just want you all to pay close attention here. Look at the chest and listen, and you might be able to see. And you see his lips are closed, so he's still snoring with his mouth closed. Okay, watch the chest. Okay. He's not breathing. He's trying, his diaphragm is trying to breathe. Can you see his body moving? And then he finally takes a breath. This happens multiple times throughout the night with sleep breathing disorders, with obstructive sleep apnea. You know, you think about the stress that it puts on your heart when that is happening multiple times per night. So that's when you start seeing the increase in blood pressure. You see more systemic diseases occurring as a result. So I think, you know, for me, that's pretty powerful to see. Just the action of the chest, and also the fact that that is my brother. So that's, you know, when it's a family member, that's when it kind of gets you. And, you know, that's kind of what I'm hoping will be a motivation for you all to be more involved in this area, because you will find somebody that you care about, that you want to help. So, you know, when I talk about hormone regulation and sleep stages and how it's important in hormone regulation, this is just one hormone pathway, your weight control pathway. And it just shows you how you have your negative feedback loop. If you have obstructive sleep apnea, you have your two hormones, ghrelin and leptin. Ghrelin says you're hungry, and leptin says I'm full, right? And they usually work pretty well together. Well, when you have OSA, they get flip-flopped, and basically your ghrelin is always up and your leptin's always down, right? So then you're always hungry and never full. You also tend to crave more carbohydrates and things like that. Appetite increases, weight gain, that leads to systemic disease. That weight gain increases the influence on OSA, because fat accumulates around the airway and further constricts it, and increases the apnea, increases the ghrelin, decreases the leptin, and you all can see how that happens. Upper airway resistance syndrome. So this would be your young, fit female. It would be your, you know, a lot of times you can get like your, you'll see activity where you won't see apneas necessarily in these patients, but you see more fragmentation in sleep, or they feel fragmentation, right? They wake up more easily. The airway constricts or decreases in size, the body detects it, and it sends like an alert response, right? It's a sympathetic response, and that's how your body basically goes into the lighter stages of sleep. So you get, it's hard for you to get into your deeper stages of sleep, but you do not, your oxygen saturation does not decrease. So I guess better way to say, it's the increase in the effort that causes a brief awakening from sleep, and it's often undetected. But a lot of times it can be detected. They're waking up a little bit more frequently. But a lot of times they just will stay in a lighter stage of sleep. So we talk about early extractions and absence of wisdom teeth. This is all based on smaller jaw sizes. Our faces have kind of grown. That's a whole nother lecture, but epigenetics is the environmental influences on your genetics, basically. And it will show you that, back 400 years ago, man's jaws were a whole lot wider, and there was enough room for all 32 teeth. Now routinely we extract wisdom teeth, and then at times we for orthodontics have to extract premolar teeth to let the teeth all fit together. Well, that is tongue space. The tongue needs that space to live. Otherwise, it gets pushed back into the airway, which further constricts it. So small faces, tough spot for the tongue to be in. It drops back. We have narrow noses. All of that leads to constriction of the airway. So a good book to, if you're just kind of like, oh, this is sort of interesting, but an interesting book that just came out this last year is called Breath, by James Nestor. He does a good job with his research. He works with dentists, and he goes through this whole thing where he puts himself through a test process. He wants to be a part of the study, and he goes through all of that. It's super interesting, and will kind of open your eyes, I think. When that came out, I bought like 15 copies and gave them to everybody for Christmas. Okay, so why is the airway so important? All the syndromes linked to sleep disordered breathing: chronic fatigue, ADHD, irritable bowel syndrome, restless leg, migraines, tension headaches, TMJ, TMD, fibromyalgia, anxiety and panic disorders, PTSD, OCD. I mean, the list goes on. And it's amazing the number of people that have come to see me that have been on so many medications, but their sleep was never tested. So that, to me, that should be the first thing tested, because if we can avoid medications, that'd be great. So a big, I guess asterisk for me, is the number of misdiagnosed patients with ADD, ADHD, because they're given a medication that essentially works like speed in the body. So that does not help. That further decreases quality of sleep. So if they didn't have a sleep problem before, they might have an increased. But the big thing is that a lot of patients can be sleep screened, and we can kind of get to the bottom of their sleep quality, try to improve, especially with kids. The number of kids that are diagnosed with ADD, ADHD is really incredible. And then we go and we give them a lifetime medication, basically, that further disrupts their sleep. One of the side effects to Adderall is insomnia. So Australia has figured it out, and they, if a child is diagnosed with ADD or ADHD, they have to be given a sleep test before they can be medicated. Okay, so children, this is, to me, the easiest area of solution, like where we can make a big impact. I think we can make a big impact. with the whole spectrum. But I think the biggest impact is with our kiddos, because we can stop that spectrum. We can stop that continuum. If we just work on their anatomy a little bit, we try to manipulate the anatomy while they're growing. If we note when we see certain things like enlarged tonsils, adenoids, mouth breathing, things like that. So sleep apnea symptoms in children, nighttime snoring, loud breathing, mouth breathing, pauses in breathing, snorting, coughing, choking, sweating, bedwetting. Bedwetting's huge. You know, a child that's still bedwetting after age 4 or 5, you know, we need to consider sleep screening. And you know, restless sleep, abnormal sleep positions. In the daytime, again, hyperactivity, behavioral issues, problems concentrating, headaches. Kids shouldn't be having headaches, you know. So okay, so this is another one, volume up. It's shorter, so y'all don't have to drudge through, but this is a little girl, and I just like y'all to just kind of pay attention to what you hear and see. So this is, mom reported, this was how she sleeps all the time. Constantly moving and audible breathing. So this isn't normal. This isn't normal. And, you know, we really need to investigate when parents report this, or if we have children that sound like this. She ended up getting her tonsils out, I believe. She might correct me. She might be on this. But anyway, this was from the nurse. My whole body doesn't feel good. And she wants to lay down during recess. What child would want to lay down during recess? You know, that's a very tired child. So little clues like this, you know, we need to pay attention. Okay, so where do we come in? It's not to say that we have to be doing anything. Let's just be aware, right? Let's make that the first step. Let's just be aware and maybe have a conversation, because there are other doctors that can do this stuff, you know, that we don't want to do. So first thing, we can recognize the mouth breather, right? The guy that sits around like Napoleon Dynamite here. And basically, you know, there are ways to do that in the dental chair. To, you know, if you can't quite tell, because some people will be, you know, can breathe through their nose, but then random times during the day they'll breathe through their mouth, or during the night their mouth drops open and they start breathing through their mouth. So what I am going to try to emphasize and to share with you all, if you're not aware, are some of the oral signs. So signs, things that we need to be aware of, so that we can kind of, you know, have an idea of what kind of a patient, you know, what we're going to be dealing with, or what they have, what their health issues might be. Obviously, open mouth rest posture. Chronic gingivitis, plaque or tartar buildup. I mean, you all have these patients, right? Your chronic perio patients, where they do everything you tell them to do. They brush, they floss, they use the water pick, they use OxyFresh, they, you know, whatever you tell them they do, and they are still periodontal patients. They still have issues. They'll still have buildup or whatnot. Well, these are that's a sign that they could be mouth breathing. I'm not saying it's the only thing contributing, but The mouth breathing dries out, it, obviously dries the mouth out, but it also decreases, it increases acidity, which is not healthy for the gums or the teeth. So you have increased caries, you have increased gingivitis, all of that. You need the lubrication of the saliva, which saliva is already going to drop down during nighttime. So we have to preserve what little saliva we have by keeping our mouths closed and breathing with our noses. So other signs are narrow arches, tooth crowding, frenum restrictions, not just tongue, also lip, but I'll touch on that just a little bit. But for the sake of this talk, I didn't want to dive too far into that. Enlarged tonsils and adenoids, or previously removed tonsils or adenoids, and scalloped tongue presentation. So clinical signs and symptoms. Dr. Nguyen, do we need to stop for questions at all right now at this point?
You can if anyone has any, but otherwise okay? You just keep moving.
Okay. So these are a few clinical signs and symptoms that I picked out of some of them, just to kind of dive into them. Narrow palate, tongue tie, worn dentition, airway, they should be flipped. Airway should be first. We should just look at that, come from the back to the front. But tori and tonsils, you'll notice the tori is connected to a tongue tie right there.
Dr. Lukin, real quick, there is a question in the chat.
Oh, okay.
Amy asked, how effective is CPAP therapy versus dental devices in OSA in kids/adults?
Okay. So that's a little bit of a loaded question. So I'll try to answer it as best I can. I think that CPAP is definitely gold standard for OSA, especially like severe sleep apneas or sleep apnea patients. Your dental devices are good for slight to moderate sleep apnea. And basically the most important thing we can do there is, titrating and testing to see. So you kind of want to have you want your baseline, obviously, baseline sleep study. And then you want to test again with whatever intervention you're using. So with the CPAP or with your dental device, to see how effective they are. And night to night, things will be different. So it's good to have a couple of nights, but yes, I mean, CPAP's a gold standard, especially for adults. Now with children, if we can get in with potentially, say, removing tonsils and adenoids and expanding palates and uprighting lower teeth and maybe influencing a little bit of the lower jaw growth, we can intervene dentally instead of putting a child on a CPAP, which sometimes that's necessary in certain cases, but we need to be careful not to over prescribe or overuse CPAPs in children because they are growing, and the pressure from the straps will impede the maxillary growth, craniofacial growth. So that is certainly a consideration in that aspect. But if pediatric sleep apnea, if it's bad enough to where that's the only option, you do that, but you also do concomitant orthodontic treatment to try to grow the jaws and to offset the pressures that are put in by the CPAP. I hope that helped. Are there any other questions or a follow-up question to that? Nope. Oops. Okay, so I'll keep going then. So for airway classifications, we use a Mallampati or a modified Malampati or Friedman. It really doesn't matter what you use, as long as you kind of measure the same way every time, because for your note's sake, you can kind of, you can help your patients out. Basically, you just want to see if you can see down their throat. When they open, can you see down their throat? Do you have to have them, say ah, and then you can see down their throat, or you can't even see, after they are saying ah and lifting their soft palate. So these are the classifications, class 1 through 4, 4 being worse, you can't see at all. And this is valid for kids to adults. So I'm always looking at airway classifications for kids as well, because if I can't see back into the airway to grade their tonsils, then I know there's a problem. There's a forward growth problem, and we need to intervene. Or not myself, I send it to an orthodontist to do that. But that's very important. So what's the connection, right? Well, the roof of the mouth is the floor of the nasal cavity. So if your palate is high and narrow, your nasal cavity is going to be narrow, or your septum is going to be deviated without having gone through trauma. So you can have a deviated septum, which means that the nostril on one side, or the air passage on one side, is constricted. Well, that is a problem, because you can't just have one effective nostril, you need two, because as we go throughout our day, our nostrils are switching dominance. So you're getting more air through one nostril while one is resting, and then they switch every 50 to 90 minutes. So you need both functioning nostrils. And nasal breathing is uber important. I think the nose is one of the most important organs in our bodies, and it's the least, I feel like it's the least respected for what it does, because nasal breathing is the keystone to health. Because your nose filters, humidifies, and it secretes nitric oxide. Nitric oxide is formed in the paranasal sinuses, and it is only released with the passage of air through your nose. So you want it secreted, because it's functioning in every organ of our body. It's vasodilating, which means we get more blood to our brain and our body. So 10 to 30% more oxygen to our brains and our body when we breathe through our nose as opposed to our mouths. It's anti-inflammatory, antiviral, which, now in COVID times, it decreases viral load when you're exposed to COVID. They're doing studies now with nitric oxide and treating, helping to treat COVID patients. So obviously immune defense, cognitive function, all sorts of things. So super important to breathe through the nose. So my whole goal for all of my patients, is, can you breathe through your nose? Are you breathing through your nose 100% of the time throughout the night? Those are kind of my two things, is that what my goals for my patients. So, okay. Another big thing, that I'm into is,
Doc, you got another question. Sorry to interrupt you.
No.
But Katie asked if in the chat, if the patient should be sitting up or laying down when assessing their airway. She usually has the patient say ah while doing their oral cancer screening, and they're laying down.
That's fine, because that's how they sleep. So I do it while they're laying down. It's not going to change too much. It's going to make it a little bit worse, but that's how they sleep. So, it's effective either way. Just do it the same way every time. That's how we evaluate them. So I just do it. Really, what I did was, I wanted to incorporate my airway screening with my oral cancer screening without changing a thing. So that's what I do. I'm looking at the back of the throat and I'm checking airway. I'm looking under the tongue for, oral cancer. That's where you look. And I'm looking at tongue tie at the same time. I'm looking at occlusion. I'm looking, all of that. It's all during the same exam. So you don't need to change a thing, in my opinion. So take that for what it's worth, I guess. Are we okay? Any other questions? We're good? Okay, so with tongue ties, right? You know, obviously we know nursing and speech, right? We know those are the big things that everybody, in fact, I was talking to an orthodontist today and he said, well, I noticed the tongue tie, but he doesn't have a problem with speech. And for me, I don't even think about the speech. Like that's not even on my radar. I have SLPs for that, you know. My thing is, okay, but where is it when they're swallowing? How are they swallowing? Are, you know, are they pushing forward or are they going up? Is it a natural swallow? Are they engaging muscles, other muscles, neck muscles, facial muscles, things like that? And then the most important to me is, how are they breathing? Are they nasal breathing? If their tongue isn't up in their palate, then their mouth is more likely to drop open and they're more likely to mouth breathe. So my big thing is, well, how are they breathing? So, and I know I'm a nut about it, but I just think the tongue is so important. This is how I classify them, functional classification. Basically, you know, how high can you get your tongue? Can you touch your tongue to your palate when you're open wide? And then kind of get a percentage range of motion from that, you know, that's a guide, right? You can have people that compensate, right? They can lift their tongue up, but then they bring the whole floor of the mouth up as well. And so that is, that's a compensation there. That is still a tongue tie. Now I can have a patient with grade 3 functioning or even grade 4. And if they don't have any symptoms, any issues or whatnot, I'm not going to encourage them to get a tongue tie release. That's if they have no symptoms and they are progressing along, they're developing just fine. They sleep just fine, no issues. Okay, great. But if I see a high arch, or if I see, you know, gingivitis, cavities, things like that, worn teeth, those are all going to affect my recommendation for these patients. This is how I do it. I have several different little tongue rulers, and I basically take a measurement of their maximum opening, and then their tongue to spot is what it's called. It's basically the tongue to the incisive papilla behind the 2 front teeth, and having them open as wide as they can. I also do a suction hold measurement. And in this one, I'm also testing kind of their motor tone or their function. Can they do a proper suction hold? And if you're wondering what that is, that's a suction hold. When you click and pop, that's what I'm looking for. Can they make a good, healthy popping sound? And then can they hold that? Can they stretch that? How strong is their tongue? So that's kind of how I measure their strength. And I get a range of motion ratio based on my measurements. Worn dentition, why is this significant? Well, the studies are showing that that sleep bruxism is related or correlated definitely to sleep apnea.
Wait, Dr. Luke will be back in a little bit here. Oh, there she is. Okay, so I'm just gonna go away now. And I think you're muted, Dr. Lukin. I think.
Sorry about that.
Hear you. Yeah.
I'm not even sure what happened. It just cut out. I might need to go into.
They lucked out. I was about to tell some dad jokes, you know. So.
You might still need to. Hang on. I'm going to get my lecture back up. Okay, let's see here. Okay.
While you're doing that, I'll just make the announcement that I'll just repeat some of the announcement. Our next meeting is going to be July 29th, and it's going to be in person, and we'll have Dr. Harold Hinson lecturing to us. So, but more information on that later. Okay, there you go. We're back.
Okay, sorry. I'm not sure where it cut me off, but Basically, sleep bruxism, the way they basically confirmed this in a study is that, and they routinely do it, and but basically they go ahead and connect the CPAP, and they have the patient, a patient with bruxism, and essentially they titrate the CPAP, they increase the pressure, and as they increase, they open the airway, and then they stop, they basically, the apneas, the sleep apneas stop, apneas and hypopneas kind of, stop, and the bruxism stops. So that's how they kind of proved the theory that now, not all bruxism is sleep bruxism. I fully understand that, but it is one of those little signs, right? That there's something going on. So is it daytime or is it nighttime? Or was it nighttime? A lot of times bruxism happens earlier in life, and then as we get older, basically the sleep apneas, it's a response, right? Typically that bruxing was a response to a narrowed airway, and so it's a jaw thrusting forward a little bit to open up the airway, to bring some more tonicity to the airway, to breathe better. So a lot of times it stops later in life because we have the apneas instead of the bruxing to open the airway and have a sympathetic bruxism response as opposed to the apnea response. Mandibular tori. Well, we know obviously bruxism is linked to tori, right? And a lot of times you'll see tongue ties associated with these tori. So that's something that you might want to kind of test yourself. When you see these tori, kind of look under the tongue and see is it what the lingual frenum looks like, because a lot of times that's associated. But a lot of our clinchers, grinders tend to develop these guys. We are now looking at removing them to increase oral volume space for patients. And so that is something now that I for large tori, I recommend removal. I send to you guys, Okay, so tonsils, huge, right? To look at the throat, look into the throat, and grade those tonsils. A child with tonsils like that, grade 4, kissing tonsils, they're not getting good quality sleep. They're not breathing well daytime or nighttime. So, in those cases, it's important to educate, the parent, and talk about it and discuss kind of the pathway, how it happens, and what the next steps are. Typically, it's a referral to an ENT, but not without evidence, right? So you'll say, they'll say that the dentist referred them. Well, typically these patients will sleep like the video that you saw earlier. So they're going to be audible breathers during the night, or moving around a lot during the night, or there's going to be some symptoms. What we encourage our parents to do is take a video or a voice memo and take it with them. If your offices have Ceph radiographs, sometimes you can see those in the Ceph radiographs. And then you can even see adenoids in Ceph sometimes. So those are helpful to take over to your ENT, because a lot of times they might just say, they'll grow out of it or something like that. But if there's a sleep component, they're going to be more inclined to go ahead and remove them. Why is this important? So a few things. Let me come through here. I just want to show this picture that I added on, just to kind of I just want to show you guys the connection between the adenoids and the tonsils. That the adenoids and ear infections, right? So once those adenoids get increase in size, they're going to stop. They're going to basically occlude that eustachian tube from the ear. So that's why these kids get more ear infections, because they can't drain into the throat because the adenoids are blocking it. So then the infection gets caught up in the ear. Adenoids will enlarge prior to tonsillar enlargement. So if the tonsils are enlarged, chances are the adenoids are enlarged or they've been removed, one or the other. But typically tonsils are secondary. So this is just an example of, I wanted to show this picture because I wanted to highlight the redness in the soft palate there. A lot of times that's attributed to like postnasal drip, or it could be reflux or silent reflux. Acidic aerosols that are brought up from the gut up into the airway. That causes further inflammation, further constriction, further loss of sleep quality. It's something to note, adults and kids alike. The other factor that it could be is friction, snoring. So I know I'm throwing a lot at you guys, but it's not like everything has to be digested. It's just, I just want to kind of touch on these things. Other potential signs and symptoms, and I've kind of gone through most of these. Dry mouth, chapped lips, that's a huge one. So cross bites, extracted premolars, those are things that to look into and to kind of be airway aware about. Like, hey, what can this do to impact the airway? And one note on extracted premolars, I'm not saying that it's going to be negative towards the airway at all. What I'm saying is it's not a positive. Extracting premolars for orthodontics, but a lot of times at that point it's necessary because the orthodontist is limited on options.
Dr. Lukin, we got another one here.
Sure.
Ask if there's any relationship between bruxism and RLS.
Restless leg syndrome? I don't know that. I'm not sure. I mean, I could see, where there could be, but I don't know. That's something good to look up. Good question. Any others right now?
I think we're good right now. I'll try to catch you on like a transition, or we'll catch them at the end.
Okay. I think we're getting there. This is one patient. Just wanted to share this because he, you can see a lot of the little clues here, right? High narrow arch, premolar extractions. Look at that fissure in the tongue, right? That's a cramped tongue. There's not enough space in that mouth for that tongue. So again, another little note, right, is that if you have a small tongue, small mouth is okay, right? It's not going to push the tongue back as much, but when you have a tongue that doesn't fit the mouth, that's a problem because it's just going to go back. And then you get your tori and your lingual frenum with an Eiffel Tower presentation. So that's kind of what we if there's an Eiffel Tower presentation like that, when they lift, that's a sign of a restricted lingual frenum. So airway aware dentistry versus airway directed dentistry. Again, being aware is a lot. That's good. That's great, and sometimes that's all we can do. With time limitations, or say your dentist isn't, on board or whatever, you're trying to get things going. You just want to be aware, right? Help people where you can. Airway directed, again, that's what, I'm, talking about some of the things that we can do in dentistry. We can refer. We can always refer. So we have a great health professional community here in Houston. And so there are a lot of options. Nasal breathing education, I think that's a simple one, right? It's cheap, effective, and it can change people's quality of life dramatically, just to breathe through their nose as opposed to their mouth. Because sometimes that's all it is. Sometimes it's just breathing through your nose. That's all, that one little thing can change so much. Frenectomies, expansion, arch expansion, advanced mandibular advancement devices, and then combination advancement devices. So you can do an advancement device with a CPAP. So you can do them in combination. Children, the earlier the better. I remember for 10 years, I practiced dentistry, and I wouldn't send patients to the orthodontist until they had all their permanent teeth. I think of all the lost opportunities in that, because now my opinion is, if we're picking between early phase orthodontics and later phase orthodontics, because insurance tends to only cover one, my vote is early, because if you create the space, the teeth will tend to drop in and look nice. Maybe a few rotations here and there or whatever. But if you put, if the framework is there, then the teeth will have room to drop in. And then again, from frenum releases, we try to prevent those extraction cases in orthodontics. Adults, again, nasal breathing education, referring, frenectomies. I put laser snore therapy in there because there are 2 lasers out there that are doing this. And it's basically like Botox for the soft palate. It's basically making the soft palate more youthful, cross-linking collagen, making it tighter. And so it lifts the soft palate and it decreases the obstruction. So that's something interesting there. And then orthodontic treatment, there are different options now, even for adults. So that's a whole nother lecture. So, but there are options out there, and Houston has a great community to get these things done. Tethered oral tissues. This is just an example. You can kind of, you can see that lift the labial frenum there. That's just a quick touch on labial frenums. These are 2 different lasers, BioLace and the Solea, and how they work. I don't know if I can play both. Oops, sorry. They're usually bloodless procedures. Fast forward through this. And so very, very low breathing. Third thing, I wouldn't do them if I had to use a scalpel. I just don't like bloody messes. So this is kind of how I do them. I do the measurements, and now I go ahead and suture on these guys so that they don't have to worry about doing exercises for those first couple of days. They're resorbable sutures, and patients respond really well to them. But it makes the first couple of days really easy. And it's nothing that, when I do these, they don't get taken out of their normal day-to-day routine. Patients do not, go out of their normal routine. Keep doing everything they're doing. They just, talking is slower and eating is slower. And that's when you'll feel a little tension, a soreness in muscles that are acclimating. But otherwise, I to this date have not prescribed any kind of pain reliever or anything for this. It's just whatever your normal pain, relief is. And this is a lingual frenum release with the Solea. Again, pretty clean procedure. All right, so this can show you some healing. so this one is open, right? But it shows you kind of it gives you an idea of what the healing looks like. Now, the frenum will redevelop. It's just going to redevelop set back. So eventually the frenum does develop. That happens to be my tongue. And this is just a picture of me when I was doing my husband's frenectomy. I let him do mine, so naturally he should let me do his, right? And then this is just an example of the CO2 snore therapy. I just thought y'all might be interested to see that. It's simple, straightforward, point and click, non-invasive. I use topical spray, that Cetacane spray, and it takes 10 minutes to do this. Maybe 2 treatments a month apart. And Laser Company states that it's going to last a year and a half. I tell my patients 6 months to a year because I've only been doing it for a year, and then COVID happened, so we weren't practicing for a long time. So still trying to figure it out, make sure that it is lasting that long before I tell my patients that. Anyway, if you want some more reading, these are some of my favorite books. In this arena, I've read a lot of books, a lot of them, and these are my favorites. So, I hope I've tried to filter. So, Sleep Interrupted, that one's really good, by an ENT. Really interesting, and one of the first books that I read. But I think that this is a good. I think all of these books on your bookshelves are good. I play with the Etch-a-Sketch. This is my my self-portrait. I think that we're all probably pretty adept at doing the hand thing, and I picked one of these up. We got them for the girls for Christmas last year, and then I stole one and started playing with it. And so anyway, that's that. Every day work harder on yourself than anything else, because if you become more intelligent, more valuable, more skilled, you can add value to other people. I mean, this for me, airway for me in dentistry, it's kind of my way of trying, my small way of making a small impact, hopefully, a positive impact on people's lives. And I hope that maybe this encourages one or two of you to also, feel like we have a purpose. We have even more purpose than I think we already did. And I was very passionate about dentistry before, and I loved it. And I loved what we do for patients, and I loved our patients. But I think this is really, really something impactful that we can be a part of. I love sunsets. And that's it. That's my contact information, my handles, and website. So I hope that I didn't make everybody drink through a water hose. But I was just trying to kind of do an overview of all these different aspects to airway and dentistry. Thank y'all for having me.
Yeah, thank you for the lecture. It was really good. Personally, I probably don't, I probably should know a lot more about, sleep disorder, conditions, and dentistry as being a dentist, and periodontists as well. So this was a good overview for me to see personally, and I appreciate you coming in and talking to all our hygienists there. We're going to open the floor a little bit. We have a little bit of time, maybe about 10 minutes, 10, 15 minutes, open the floor a little bit to some questions. And I think we've got one already from Maggie. And she asked, what's the youngest patient you've treated?
So I've done, I guess, airway evaluations or consultations, I'll do them as young as, typically my cutoff is like 6, 7. And then tongue ties, things like that. I have a pedodontist that I know and trust and love. So I usually refer those patients for, evaluation of restricted oral tissues over to them. And then I see 7 and up to do that. Now, airway consultations, probably, I guess as young as 4, but for the treatment, that all goes to other people, but it's just a matter of having somebody that like says, okay, so for this, go here, for this, go here, for this, go here. So it's, that's pretty simple at that age, at the younger ages. It's much easier. So a side note on that, those patients 4 to 6, those are hard ones to get to the orthodontist because they're still not quite there. So what I do with those patients is I tend to recommend habit trainers to see if they'll utilize the little habit trainers. I should have had one here that I could show y'all, but they look like MyoBrace or Healthy Start appliances. I just have these cheap ones that I just have them try because that's what I did with my daughters. And I started my youngest, I started her at 2.5. I transitioned her from the pacifier directly to an infant trainer. And she still sleeps with a habit trainer. And she's going to be 5. So once she hits around 6, I'm going to reevaluate and see what, if she needs any orthodontic intervention at that point. But right now she has spaces and she's got a good arch. She's an obligate nasal breather. But before that, I have pictures in another lecture, but she was anterior open bite, and narrow airway. But yeah, I treat a lot. I mean, I usually treat the older 7 to whatever age. I've done frenectomies on 60 and 70-year-olds.
Maggie had a follow-up on that, in that, do you get the infant trainer through you, or do you have to get the infant trainer through you, or is it over the counter?
No, you can get it. So I go through AZ Dental, and I started like just on Amazon, buying them on Amazon, and then I went to the company directly, and they're so cheap. They're like $4 each or something like that. So, because I don't have the resources to follow up and to be getting them in to check them. And that's why these, like MyoBrace, Healthy Start, these systems are so expensive, is because there's a lot of follow-up. There's a lot of in-office appointments that they need to do. So they have to use their resources to do that. I don't have that. I'm an associate in Katy, and I'm not in Sugar Land all the time. So I just don't have the resources to do that. So that was my way of kind of, trying to be actively doing something or trying to help them. But, the best thing you can do at that age is educate the parent a little bit. Just set them up, just have them read, listen to a podcast or read a book. There's tons of great ones. So just having them be aware, and then they can like start, watching the mouth breathing and all of that.
Okay, we got another one here from Kara. Oh, Katie said your etch a sketch art is amazing. So go ahead and give her a follow on Instagram then. And
to do one in forever.
Well, Kara asked, do you recommend myofunctional therapy before frenectomy, etc.? I do.
So it's a process. I have them, I evaluate them. And at this point, what I do, if they're referred to me, I do a Zoom consult, but they don't get the Zoom consult until they have already filled out the paperwork, which is a big questionnaire, goes through their speech, sleep, nursing history. and then other potentially related issues. And they also send in, typically they'll send in a couple of photos that we have a template that they kind of follow just to send, take pictures with their phone and send those in. And then we do a free Zoom consult and kind of address any questions, kind of tell them the process and make the referrals. So then we refer, if they haven't been referred from an SLP, I will make a referral to an SLP in their area that is trained in myofunctional therapy. And then they'll start the evaluation process there. If they need expansion, I typically will have them do the expansion first. So they go to the orthodontist and the SLP. And then they may initiate therapy with the SLP or the myofunctional therapist. But the orthodontics, typically we do that first, because my goal is for them to get the arch expansion, because I can do the tongue tie release whenever, but the jaw won't expand. We're limited in how much expansion we can manipulate by their growth. So the younger they are, the more growth potential they have, and the more we're able to intervene and manipulate. But once they get to like that puberty time, then we're very limited on how much basal bone expansion we can get. Otherwise, it's just endoalveolar, so we're just tipping. So it's super important to get in there early. I forgot what the question was. Where was it? Sorry.
Yeah, it's okay. Recommend myofunctional therapy before frenectomy.
Before and after. Sorry.
Before and after. Okay.
Yeah. Then basically they get to the point where they can do a suction hold, like I was showing you. And if they can't, if they're so anteriorly tongue-tied, I'll release the front portion. I'll release the front portion right away and do a two-stage. So I'll do that. They can go get the expansion, but that just gives them more mobility. And then they're more able to kind of to start working those exercises. Usually the SLP will ask me, hey, can you go ahead and do a first stage so that I can get them to do these exercises better, so I can get that some more range of motion. And then I'll do that and then do then they'll go through myofunctional therapy and they'll come back typically once the myofunctional therapist thinks, okay, hey, they're at a point where you can, I think you'll be able to address them, and they've got some good motor tone. They've got good strength in their muscles. So I think they're at a good spot. So then we'll do the second stage of functional frenectomy. And where I'll have them suction hold and I'll try to go and release it down to the muscle. And then they do myofunctional therapy after that. So with the therapist, and then it's like a set start and end. So a couple more weeks of therapy after that. Depends on the patient.
Okay. All right. Well, thank you for answering those questions. I don't see any other questions right now, so it's probably a good time to kind of tie things, tie a bow on this. And a few more things I will. For those who missed, I will send out, like we've done before, we'll send out the CE verification survey to help, and I'll get the survey results over to Dr. Lukin so she can take some feedback, and we'll send a recording as well as the slides from the lecture. So thank you, Dr. Lukin, again for presenting this very, very interesting topic. We can, down the road, we can maybe try to go a step further and, learn more about this in a live setting more so than a webinar.
Great. Thank you all for having me.
Thank you, and have a good night.
Okay, you all too.